Hello everyone. In this series of lectures, we'll be discussing pathophysiology of urine production and use this knowledge to understand, diagnose and manage patients with decreased urine output and renal failure. This is one of the most common situations that you'll encounter in your hospital when the nurse calls you with decreasing urine output. And most common answer I hear from residents is that you will give a liter of lingual lactate either as a bolus or starting them on 100 cc's an hour of IV fluids. Even though this may seem to be a reasonable answer, in a certain group of patients, it will not have any effect, and in others, it can even result in worsening renal function. This decision making can be more complicated if the patient has acute heart failure or underlying renal disease. We'll discuss how to approach this issue when we have understood all the moving parts of this, so stay with me. If you have a bird's eye view of the kidneys, you can see that the urine output will depend upon the renal blood flow, amount that is filtered through the glomeruli, and the amount that is reabsorbed in your tubules. However, you have only one parameter that's available to you, that's your urine output. You may have some idea about renal blood flow if you look at your blood pressure, but most of the underlying renal functions are hidden away from you. So let's figure out what is hiding in the black box. Kidneys receive around 20 to 25% of the total cardiac output, which is around 8 times more than the brain per 100 grams of tissue. Renal medulla has very high metabolic activity for its mass. It consists only 0.5% of the total body mass, but uses around 7% of total oxygen. However, around 95% of the blood flow that goes to the kidneys goes to the cortex, and only 5% ends up in medulla. And you would think that it's a bad design. However, the renal blood flow is structured in this way because if the blood flow in the medulla is high, it will wash out the concentration gradient that helps you concentrate the urine. But that certainly does make kidneys more susceptible to hypoperfusion, as certain areas in the medulla have very low PVO2, as low as 20. Renal blood flow depends upon two physiological principles, myogenic response and tubuloglomerular feedback. Angiotensin 2 helps regulate some of the myogenic response in a process called autoregulation. Autoregulation is mostly myogenic response, and this is very simple to understand. As the stretch on the wall of an arteriole increase, the arteriole constricts in response. Myogenic stress receptors are present in the afferent arteriole, but not the efferent arteriole. So if your mean artery pressure would rise, the arterioles will vasoconstrict, and if mean arterial pressure were to fall, the arterioles will vasodilate. And this keeps the renal blood flow constant, and this helps keep the GFR constant. However, this happens only in range between 70 to 170 millimeters of pressure. Myogenic response breaks down at very high and very low pressures. So at MAP less than 70, autoregulation starts breaking down, and at MAP more than 170, you start noticing glomerular injury. And as your mean arterial pressure drops to less than 50, no urine production happens. So don't act surprised when your patient stops making urine and you notice a MAP of less than 50. The corollary of this is if your patient does not make any urine, most likely his renal perfusion pressures were less than 50 for quite some time. Remember that it's not the systolic blood pressure that perfuses the kidney, it's the mean arterial pressure. So make sure that you keep your mean arterial pressure more than 65. And in certain situations like renal congestion and abdominal compartment syndrome, you might have to keep the MAPs even higher. One of the commonest things missed on the hospital floor is the urine output monitoring in patients with borderline blood pressure. So urine output is low for hours before getting recognized. Note that you take blood pressure intermittently, and there are pretty good chances in these patients that your blood pressure were low for quite some time in between the measurements. So always ask your nurse to watch the urine output in your hypotensive patient. Different disease process change the threshold for autoregulation. So mean arterial pressure of more than 65 are not for everyone. For example, in patients with chronic uncontrolled hypertension, their threshold for autoregulation is higher, so urine output will drop at relatively high pressures. So if these patients' mean arterial pressure are 70, you would still see decreased urine output and renal failure. In patients with diabetes, the range of autoregulation decreases. Angiotensin is one of the important hormones that helps autoregulate, especially at lower blood pressure. If you remember from a previous lecture, hydrostatic gradient is pressure in the afferent arteriole minus pressure in the efferent arteriole minus Bowman capsule pressure. If your MAPs are decreased, you have decreased hydrostatic gradient, and that tends to decrease the GFR. Angiotensin 2 is secreted in these situations, which tends to increase your mean arterial pressure. It vasoconstricts both afferent and efferent arteriole. However, efferent arterioles are relatively more constricted, and since they are much smaller in size than afferent arteriole, similar amount of vasoconstriction results in much higher increase in resistance, because you remember that resistance is inversely proportional to the radius to raised power 4. Angiotensin therefore maintains the hydrostatic gradient at lower blood pressure and maintains the GFR. Angiotensin causes vasoconstriction and reduces renal blood flow, but maintains hydrostatic perfusion pressure gradient, and this maintains your GFR. If you give this patient ACE inhibitor, you're going to cause vasodilation of both afferent arteriole and efferent arteriole, and your renal blood flow will increase. However, because it also causes drop in systemic blood pressure, at certain point, it will start dropping the renal perfusion as well, and will result in decreased GFR. This would explain why ACE inhibitor cause worsening renal function, especially at lower blood pressures. So angiotensin 2 antagonist result in dissociation of renal blood flow and GFR, so they should not be used in patients with low or borderline MAPs. Any renal hypoperfusion is a stimulus for renin release, which converts angiotensinogen to angiotensin 1 and finally angiotensin 2. Angiotensin 2 also has some other function besides improving your mean arterial pressures and renal vasoconstriction. It also vasoconstricts glomerular mesangium, therefore decreases the volume loss. It also decreases surface area for filtration. It increases the sensitivity to norepinephrine and helps release of norepinephrine as well. It also sensitizes afferent arteriole to tubuloglomerular feedback, which we'll talk about in later slides. Angiotensin 2 also helps in salt and water retention in proximal convoluted tubule and stimulates aldosterone production for salt and water reabsorption in distal convoluted tubule and collecting duct. So if you understand this, you should be able to understand why ACE inhibitor cause renal failure in patients who are most susceptible. Let's take an example. This is a patient with bilateral renal artery stenosis with decreased perfusion to the kidneys. Both the kidneys will be myogenically regulating their blood flow by afferent vasodilation. They will also be producing a lot of angiotensin 2, which would increase your blood pressure and result in secondary hypertension. And this should tend to perfuse the kidneys and try to maintain the GFR. If you give ACE inhibitor to these patients, your blood pressure falls down and your autoregulation is reduced. This would result in decreased renal perfusion and decreased GFR, and in certain cases, renal failure. In fact, aggressively treating hypertension by any medication in this condition will result in similar drop in GFR and renal failure. Let's see what happens in unilateral renal artery stenosis. In this, your left kidney is underperfused, so it's going to produce angiotensin 2, resulting in secondary hypertension, and this would try to maintain the GFR in this kidney. However, on long term, it's going to damage the right kidney. The right kidney is myogenically regulating by afferent vasoconstriction because the blood pressure is pretty high, while the left kidney is myogenically regulating by afferent vasodilation. If you give this patient ACE inhibitor, you would certainly lower the blood pressure and reduce perfusion to the left kidney, while the right kidney now gets perfused better because it doesn't have to do vasoconstriction anymore. So sometimes you will not see any changes in creatinine in this condition, even if you give ACE inhibitor and you lose one of the kidneys. So risk of renal failure with ACE inhibitors can occur in any condition in which renal perfusion pressure is reduced. GFR may fall in some patients on ACE inhibitor, and these are the patients with elevated angiotensin 2 activity, which is seen in heart failure, hypovolemia, hypertension, or any other reason that would stimulate your angiotensin 2. Angiotensin 2 causes peripheral vasoconstriction and maintains the blood pressure. It causes vasoconstriction of afferent and efferent arterioles and maintains the hydrostatic gradient and reabsorbs sodium and water to improve the blood pressure. And if you give ACE inhibitor in these conditions, you would decrease the hydrostatic gradient, decrease the GFR, lower the blood pressure, and decrease the reabsorption of sodium and water. So let's talk about tubuloglomerular feedback. These are alterations in the GFR which are induced by tubular flow. In fact, this is a feedback mechanism that is coming from macula densa in the distal convoluted tubule, which is sensing the flow and trying to correct the GFR. It is very easy to misunderstand this. The normal thing that you would presume that as your GFR goes down, the urine flow to the distal nephron should go down as well. Or if the urine flow to the distal nephron is low, the GFR should be low. However, when you measure the distal nephron flow and plot it against the GFR, decreased distal nephron urine flow results in increase in GFR. So why should this happen? DCT, as you know, has limited capacity to handle volume and salt and accounts for less than 5% of the total. The tubuloglomerular feedback prevents overwhelming of the system. Therefore, if your GFR is high, the TGF will reduce the excessive loss of salt and water by afferent vasoconstriction, therefore reducing the GFR and therefore reducing the flow to distal tubule in these circumstances. And if your GFR is low, TGF will maintain the GFR by afferent vasodilation and therefore maintains the distal flow. Let's see how this happens. This is a patient with increased effective circulating volume and increased GFR. You will have decreased sodium and chloride reabsorption PCT, which will result in increased amount of urine rich in chloride reaching the distal tubules. Chloride absorption by sodium potassium 2 chloride in macula densa result in stimulation of ADP and formation of adenosine, which is going to constrict the afferent arteriole. ADP also inhibits production of renin in JZ cells. Therefore, you will not have any renin release and therefore decrease angiotensin 2 activity. If you remember, adenosine causes vasodilation in all other part of the human circulation, but not in kidneys, where it causes vasoconstriction. Vasoconstriction of afferent arteriole is going to lower the GFR and decrease the amount of urine reaching the DCT. If you have hypovolemia, your GFR is decreased and you'll have increased sodium and chloride reabsorption in PCT. This will result in decreased chloride load in macula densa cells and therefore no ADP is generated and JG cells can make renin, and since there is less amount of adenosine and increased production of prostaglandin E2, this causes vasodilation of the afferent arterioles and this will tend to increase the GFR and increase the amount of urine reaching DCT. One of the major clinical implications of this is why your patient stops responding to loop diuretics. Since loop diuretics block sodium potassium 2 chloride channel, they reduce the chloride level in macula densa, therefore increase the renin secretion. And this is why you observe the braking phenomenon, which is decrease in urine output with time seen with loop diuretics. You understand that increase in renin stimulates angiotensin 2, which results in increased salt and water retention. So autoregulation and tubuloglomerular feedback stabilizes sodium chloride delivery to distal nephron, thereby preventing excessive salt and water losses. One of the thought in this regard is that maybe it's not the GFR that your kidneys are trying to maintain, but rather the tubular flow, since distal segments have limited reabsorptive capacity. It also maintains GFR and urine production and helps renin release. Under normal and abnormal circumstances, both of these are the most important mechanisms that regulate renal hemodynamics. However, in renal hyperperfusion, some other factors also come into play, like sympathetic nervous system, renin-angiotensin aldosterone system, dopamine, prostaglandins, atrial natriuretic peptides, endothelin, and nitrous oxide. We'll discuss about these in next lecture. Thank you.